Renal replacement therapy gives supportive management for patients with severe acute kidney injury and multi-organ failure. Now we are heading towards panel discussion on renal replacement therapy in ICU. I invite Dr. Ankur Bhavsar as moderator for the panel discussion. I invite the panelists on the stage. Dr.Tejas Parikh. He is consultant intensivist, Zydus Hospital, Ahmedabad. Dr.Maulin Shah is consultant nephrologist and transplant physician, Shri Krishna Hospital, Karamsad, Gujarat. Dr.Hardik Patel is consultant nephrologist, Muljibai Hospital, Nadiad. Dr.Revathi Aiyer, consultant intensivist, Sterling Hospital, Vadodara. I request Dr. Ankur Bhavsar sir to proceed for the panel discussion. He is critical care consultant, MBBS, DA, IFCCM, EDIC. His head critical care unit, Spandan Multi-Speciality Hospital. His area of expertise is rational use of antibiotics, sepsis and ARDS.
Morning. So we further proceed in acute kidney injury in ICU. It is one of the very complex and sometimes really difficult to determine when should we start. Many patients have creatinine of 1, still they are oliguric, anuric, and many patients have 5 creatinine, we have good urine output, and some patients have 1 creatinine with anuria. So when should we start renal replacement therapy? How should we go ahead? What are the complications? For that we have eminent panelists, and for their help we can fix all the common issues in renal replacement therapy in ICU. So basically it is around 40% of patient generally, if in our ICU around 30 to 40% patient generally developed AKI, and 5% patient may require renal replacement therapy as per various studies, if we can see. So around 35 to 70% patient may require renal replacement therapy. So we'll go one kind of hypothetical case from which we can discuss. So male 71-year-old, known case of COPD, and was admitted for COPD exacerbation and was discharged. At that time he had normal renal function test, LV function was normal, was given normal beta lactam plus macrolide, and was discharged uneventfully. Now this time patient comes with the chest pain, breathlessness, and patient was severely hypoxemic, so required intubation, and immediately after intubation ABG was done, which was suggestive of severe metabolic acidosis, lactate 2.6. This was after intubation, so PO2 was high and bicarb of 18. WBC was 19,000, CRP 167, pro-BNP was 900, PCT was 2.5. X-ray bilateral haziness, and this time LV dysfunction was noted around 35%. So we'll start. Doctor, can you, Dr. Revathi, what are the risk factors when patient comes to our ICU? When we anticipate that this patient may go into AKI and may require renal replacement therapy?
So basically, am I audible? Yeah. Any patient who is elderly, diabetic, hypertensive, patients who have liver disease like cirrhosis, like in this case sepsis, patients of severe infection and sepsis. Absolutely. In shock, most of them, many poisons in toxicology patients, in patients of snake bite, so these are some of the patients who we should expect they are going to go into acute kidney injury. So, and already who have CKD, again they run a higher risk of having AKI.
So any patient from admission only we can make out that what this patient might go into AKI and may require renal replacement therapy, so that from admission itself we should start thinking how to avoid AKI and we can prevent those things. So these are the risk factor: old age, hypertension, CKD, heart failure, diabetes, cirrhosis, greater severity of illness, and abnormal hemodynamics, sepsis, hypovolemia, and high SOFA score. So in this patient, we have a lot of like sepsis, LV dysfunction, old age, diabetes. So this patient probably may go into AKI. So these are the studies. The majority time in ICU, sepsis is one of the leading cause, around 50%. Major surgery and hypovolemia and obstructive uropathy. These are the common causes. So we further proceed. Patient was on mechanical ventilator. FIO2 remained same. So oxygen requirement was not high. Urine output last 12 hours, around 12 hours. ABG now, if we see bicarb 16, lactate has come down to 1.3. Patient is not on vasopressors, and creatinine has increased to 1.7 from 0.8. Dr. Tejas, as we all know, there are definitely AKI classification and AKI criteria. Just to summarize, can we have some kind of staging in this AKI?
Yeah, so there are basically three kind of staging is available. One is the rifle criteria, second is Akin, and third is the KDGO. More or less all of them, they are almost the same. So in stage 1 they have what we call as 1.5 times elevation of creatinine, and in stage 2 it will be 2 to 2.9 or say 3 times the elevation of creatinine, and stage 3 would be more than 3 times or 3 times the elevation of creatinine. There is also a urine output criteria which tells about if the urine output is less than 0.5 ml per kg per hour for 6 hours in stage 1, 12 hours for stage 2, and less than 0.3 ml per kg per hour in stage 3. And the rifle has got another two, that if this renal failure persists for 1 month, it is failure, and loss is ESRD if it is for 3 months.
Yes, so obviously this is just to have idea which stage we are in and which, so it is very uncertain at which stage patient will require renal replacement therapy. But so according to this, we are in probably stage 2 in this patient. So this Dr. Bhagesh has already enumerated very nicely about the biomarkers also. So there is also we can have some biomarkers. So this is already been described well. So Dr. Maulin, so this is stage where patient is on stage 2 AKI and borderline urine output. So what should you do at this stage? Will you consider going for directly renal replacement therapy, or would you like to wait and watch? So how should we proceed? This is very common scenario in ICU. So many times we have a lot of dilemma. Should we immediately dialyze? Should we wait? So what are the criteria for dialyzing immediately, or we can wait for some time?
Yeah, so certainly we can wait in this case. As of now, there is a stage 2 as per urine output as well as serum creatine criteria. So there are so many RCTs now available in last 6-7 years. So I will quote few of them. One is AKK criteria, AKK RCT. It was done in France. Result was available in 2016. And what they did, they randomized almost 600 patients into 2 groups. One group was early or immediate RRT initiation, and other was the standard. So they included patient with oliguria more than 72 hours, right? So they, when in the early group, when they randomize, they immediately start on RRT.
Yes.
And in the late group, they waited till absolute indication happens, right? So
Yeah.
what did they found? The result was there was no difference in mortality. But the interesting observation in this trial was the patients who were started on delayed RRT group, they had, in fact, 50% patient did not require RRT at all, and no mortality difference. In fact, complications, CRBSI more in early group. So this trial favored, suggested there is no definite evidence to start early. Similarly, START AKI, which is in fact a multinational, multi-center trial, they randomize almost 3,000 patients in 2 groups. One is accelerated strategy and one is standard. So in fact, in those 2 groups also, they found no difference in mortality. And in fact, in this trial with large sample size, almost 40% patient in delayed arm group did not require RRT. So they, in fact, they also conclude that early RRT initiation is not helpful. And recently, of late, we got AKIKI 2 trial. This is very interesting trial because they randomize two subjects into two groups, that is delayed versus more delayed strategy. Delayed, I mean to say, the inclusion criteria in this group was when oliguria persisted for more than 72 hours or urea is very high, more than 240, then they included these patients. And in the delayed group, they started RRT immediately after randomization. In more delayed group, they even further monitored the patient, and they started once there is absolute indications like refractory hyperkalemia or refractory overload, refractory, not immediate sort of, right? And or urea is going more than 300, then they started RRT. Now in this group, what they found that mortality was more in more delayed group, right? So it was almost 55%, while in early group or the delayed group it was around 45. Although it was not statistically significant because of small sample size, but definitely mortality was high. So definitely we should not wait till this much late or absolute indication happens. So in a way it is rather complications of AKI.
Yeah.
So we should not wait till that happens.
Yeah. So the message is very clear. So we can delay, we can just closely observe the patient, we can observe the potassium, acid base balance, volume, but then we should not do too much of delay also. So because that will increase the mortality and then patient might worsen. But as of now, we have plenty and ample of evidence which suggests that if patient indication of dialysis are not very urgent like hyperkalemia, acidosis, then we can play with, I mean we can wait for some time, we can closely observe the patient, but do not cause too much of delay which will harm the patient. So as Dr. Maulin has mentioned, in this AKK 1 trial, around 50% patient did not require dialysis at all. So that signifies that we can wait for some time and there was no difference in mortality. So there is one more meta-analysis which also suggests a similar finding, and the one more START AKI trial which he has mentioned. So message is that we can wait if there are no urgent indication, and then we cannot do too much of delay. So this is what, though it was hazard ratio of delaying was around 1.65. So in severely AKI patient, oliguria more than 72 hours or BUN more than 112, no severe complication, that would mandate immediate RRT. Additional delay did not confer additional benefit. So we can delay, but not too much delay is also not good. So Dr. Hardik, yeah, please.
Can I add a few things put to this?
Yeah.
One more important thing is because what kind of kidney injury, it is only single organ or multi-organ, and what is underlying cause. If your underlying cause is likely to recover, like your diarrhea has now stopped. If it is patient has a cardiogenic shock, your cardiologist is willing to do a plasty and his cardiac function is improving, then certainly you can wait. If your underlying cause is unlikely to recover in next 24 hours, I don't think that we can push it too much.
Yeah. So of course, along with the help of nephrologist, we can see patient as a whole and not only seeing only kidney part. So many of the time AKI cause is reversible, so patient is likely to recover. But if we think that this patient is not going to recover, then we can also consider. So it's not immediately, it's not urgent, and so we have to coordinate with the clinician, nephrologist, critical care consultant, and then we can take a call. And of course, Dr. Hardik, when do we require urgent? So that this is all we know, but just to have more data, information, when we should be immediately dialyze.
So there are clear-cut indications like hyperkalemia refractory to medical therapy, acidosis refractory to medical therapy, volume overload, and in certain situations where you do early like poisoning because of dialyzable drug, then you don't wait to AKI to set in, you dialyze them upfront also. In certain situations, even with severe lactic acidosis, when your renal function are not that bad, and you know this because of drug induced, you can dialyze them early. And when you don't understand what is happening to the patient, like unexplained encephalopathies in a kidney failure patient, where other causes has been ruled out, uremic pericarditis, unexplained hypotensions. So whenever we don't understand anything in a kidney failure patient, we tend to dialyze them.
Yeah, absolutely. So again, message. Many times patients are hypotensive, lactic acid is not improving. So the no point in giving bicarb and giving diuretics. Such patient will require as early as possible renal replacement therapy, so that patient may become hemodynamically stable. And of course, poisoning patient will require early removal of the drugs. So yeah, and sometimes, as we already mentioned, some patient so what are the problem when we do urgent dialysis and we can delay, like patient we can wait for dialysis for some time and we do urgent dialysis. So is there any problem if we do early dialysis? What are the problems?
Yes, anything done in emergency always has its own problems, because it is not, dialysis is not a benign therapy. We can start with everyone like ventilator. There are complications of dialysis also. Starting from line insertion, you can have a complication of line insertion, especially septic AKI, thrombocytopenia, platelets are low, they are in DIC. The moment you do line insertion and there is something wrong, you will end up in other emergencies rather than actual patient's condition. And there are complications of dialysis itself also. When you do too vigorous dialysis, you produce hypotension, you are exposing patients to the extracorporeal therapies, which are again highly immunogenic. So these are again, you can perpetuate the AKI also, underlying condition also. So you should always remember dialysis is not a benign therapy. There are a lot of complications related to dialysis also. And especially in a critical ill, where the potassium sometimes are on lower side, sometimes on higher side, and we generally don't look at the dialysate potassium very frequently. We standardize dialyzing therapy to everyone. Then again, you are increasing the risk, you are taking the risk of arrhythmias, and a lot of high electrolyte fluctuation like sodium, we can move from one side to other side. So this is not benign therapy. That should be kept in mind and whenever you are dialyzing the patient.
So it's like double-edged sword. We have to justify what we are doing. So if patient is stable, we can wait, but if there are urgent cases, we should consider.
Dr. Ankur, just a minute.
Yeah.
Many times, I just want to add thing.
Yeah, sure.
Many times, if we start dialysis early, we always see that the renal recovery is usually delayed. Because we are dialyzing this patient, we are removing urea.
Yeah.
Urea is very osmotically active. So many times high urea, of course in acceptable range, it is more of a osmotically dragging thing and it produces urine.
Yeah.
Once you remove urea from your blood doing by dialysis, immediately you will find that next day output will drop. So this is happening,
Yeah.
right? So early dialysis may delay renal recovery,
Yeah.
and as Dr. Hardik suggested, recurrent hypotension, it actually increases AKI further and further.
Yes.
So it harm in that way
Yeah,
also.
so this we should remember. So as everybody has seen, once we dialyze, whatever urine output of 500 ml per day come down, so almost patient becomes anuric. So as we all know, the complication of dialysis catheter, hemodynamic instability, and so this is also very important. Risk of excess clearance of subtherapeutic level of vital medication like antibiotics. So we have to manage that, and delayed recovery. So basically, in short, if patient requires urgent, we should start. If not, then we have to just we have to do very close observation, and we have to closely monitor. And as and when we feel that patient is either hyperkalemic acidosis, we should urgently dialyze the patient. And meanwhile, we should optimize hemodynamics, give antibiotics, optimize cardiac output, avoid secondary kidney insult, avoid nephrotoxic drugs, and then we just closely observe. So ultimately, this patient later on required dialysis. So which modality is preferred, Dr. Revathi, in ICU? In such kind of patient, there are 3-4 options. So which modality is ideal, and what are the reason for opting any of the therapy?
Yeah, I think at least in adult ICU population, peritoneal dialysis is no longer done. Previously, in the ester years when it was difficult, that was practiced. That is more now for routine home patients who cannot come to the dialysis unit. So we do hemodialysis. In hemodialysis, intermittent hemodialysis can be done, which is usually done in CKD patients in the dialysis unit. But the disadvantage is there is a higher flow rate, higher volume removal, and the duration is less, maybe 3 to 4 hours. So in critically ill patients who are hemodynamically unstable, this modality is not very safe. So we prefer other modalities like SLED or CRRT. CRRT, where the staff and all the paraphernalia is there, yes, it is good in hemodynamically unstable patients. But when you do not have the CRRT machine or you do not have dedicated staff to monitor it for 24 hours, SLED is good enough. SLED is what we also practice in our ICU. It is done for 6 to 8 hours. Slow dialysis, the flow rate is less. And the dialysis runs smoothly even in patients with high inotropic support. The one more advantage is once the SLED is over, the other procedures and other things can also be done. Only thing is there is a slower clearance of the fluid, but it is more hemodynamically stability is achieved. So I think we prefer SLED. CRRT is also a good option. The studies show that there is no difference in mortality benefit between CRRT and SLED. So I think we should use the mode which we are more comfortable, one of these in our critically ill patients.
Yes, so yeah, of course CRRT is good, but then we have to see our logistic also. So what are the advantage, disadvantage of CRRT, Dr. Tejas?
So as madam described, that CRRT is more feasible, or rather should be done in a patient who are hemodynamically unstable, those who are on multiple vasopressors, as well as those who have got an intracranial problem. For example, if we have a hepatitis causing hepatic failure, acute liver failure, and they are posted for transplant, those patients, it is preferable that intracranial pressure should be, good enough. The CRRT takes care of that. So in those patients, it is preferable to do a CRRT. The advantages are, of course, it causes slowly removal of the fluid, so the patient can tolerate it, and hemodynamic stability is the first target. Second is reduction in the ICP. So these are two important things, areas where we would like to use CRRT. The disadvantages would be, as madam said, that procedures and mobility of the patient for for CT scans or MRI, or that is hampered in cases of CRRT.
So yes, obviously, so both have plus and minuses. So we have to we have to see patient as a whole and our logistics also. But the important issue is that when patient is with raised ICP, so this IHD causes a lot of disequilibrium syndrome. So it is preferred when patient is on CVH is preferred when patient is on with hepatic coma or trauma. So as of now, there is no study which is showing one age of one modality or others. And so this is the routine. Peritoneal we are not doing. Sustained low efficiency dialysis is in between IHD and CVVH. And as we have already discussed, IHD is associated with more hypotension, dialysis disequilibrium syndrome. CRRT is preferred when there is hemodynamically unstable patient. It causes no increase in intracranial pressure, and SLED is probably in between to this modality. So one of the common issues which we encounter while doing IHD is hypotension. So is there any way we can prevent hypotension because majority places CRRT is not available. So practically if we want to see what are the methods to prevent the hypotension while patient is going intermittent hemodialysis. Dr. Maulin. Yeah.
Yes, so intradialytic hypotension in this patient is very common, and always whenever somebody is being dialyzed, there has to be intact or good compensatory mechanisms. So I am talking about three important things. One is plasma refill or vascular refill. Other is sympathetic activity which should increase, and third is increased cardiac output when dialysis is being done, right? So most of the time what happens, patients are overloaded. So to remove more fluid, more ultrafiltration rate is set, and that ultrafiltration rate is more than the vascular refill rate. So that is the commonest thing which is responsible for intradialytic hypotension. So I always suggest to reduce the UF rate, rather increase the duration, as we have mentioned the duration of 6 to 8 hours, or even prolonged duration is possible if we want to remove more fluid depending on the patient's condition. So one is reduce UF rate, daily dialysis will be helpful, that is daily SLED. The other important thing is dialysis temperature. So we many times get benefit of hemodynamic stability with CRRT because of dialysis temperature. We are using cool dialysis in CRRT. So that is the main thing why CRRT is very useful in hemodynamic unstable patient. In fact, in SLED patient also, we can manage temperature, we can reduce the dialysis temperature. Usually difference we keep around 0.5 to 1 degree centigrade between patient's temperature to the dialysis temperature, right? So, but remember one thing, whenever we are reducing dialysis temperature, your patient may not throw fever in ICU, because we are exposing this patient to 6-8 hour dialysis we are modifying the core body temperature. So that thing may not happen. So fever thing may not appear, that things to be kept in mind. Third important thing is increase the dialysate calcium, which is very, very important to manage, to prevent intradialytic hypotension.
I think
Fourth
4-5 minutes more.
Fourth thing, what we can suggest, the use of albumin or even mannitol, even hypertonic saline. Okay. Albumin has advantage definitely, because all these three they increase the osmolarity. So increased osmolarity will lead to less fluctuation between two compartments. So intradialytic hypotension will be less. Albumin will have advantage in terms of nutrition also. So we can use albumin also. We can use mannitol. Mannitol in AKI, there are not many papers, but in ESRD patients now we are having good evidence. So that also can be used, but of course with caution. Fine.
So this is anything to add? Yeah, please.
So maximum diet happens at the beginning of dialysis. So I always tell them ki don't do ultrafiltration in first hour if there is it is not an urgency. Second, because dialysis circuit itself has a volume of 250 ml. So if we want to give blood, prime that circuit with the blood or prime the circuit with albumin, and because in normal dialysis they do remove 250 ml of, let the blood come out, then they connect. So we ask them to do end-to-end connection. These are the things which can prevent the hypotension episodes at the beginning, which will help you to continue dialysis longer.
So there are some measures which we commonly encounter. So priming the circuit with the albumin, saline, or keeping low temperature. These are the helpful things. Anything related to sodium, sodium?
Sodium profiling we can use. Many times we use in ESRD patients in routine intermittent hemodialysis session. So we can start with the high sodium bath at the initiation of dialysis. Say for example up to 155 dialysate sodium, and then we can go down to 140 over a period of 6 hours, 8 hours. In ESRD patients, our experience with the high sodium bath is patient usually have more intradialytic weight gain. But in this patient, that is not an issue. So it should work. And as such, if you talk about the evidence, because of small sample size, there is no significant evidence we have, but we can definitely use, theoretically, we have good basis to use that.
Okay, fine. So these are we have already seen. Albumin we have already discussed. So Dr. Hardik, is there in 2000 when there were some studies which suggest if we do dialysis very aggressively, like daily dialysis, or if we have a dose of like 35 to 40 to 50 ml per kg per hour, those patients may recover early or they may require a less time of dialysis free. I mean, they can become dialysis free earlier. So is there any such indication? What is the latest recommendation?
So again, dialyzing dose, it depends, differs from modality to modality. Like for intermittent hemodialysis, you have KT by V, which we can monitor pre-dialysis urea and post-dialysis urea. And in CRRT, what rate of fluid we are using, that becomes a dialysis dose. Again, I will divide the patient into two categories. AKI where there is only single organ involvement, only kidneys are affected, versus AKI with a multi-organ involvement, like you see in a critical care ICUs, multi-organ failures, patients are on vasopressors. If the AKI is only single organ involvement, diarrhea, AKI, ATN, drug-induced ATN, where the patient is now stable, intermittent hemodialysis 3 times per week, and if you are able to achieve KT/V target of 1.4, that is good enough. There is no advantage of doing daily dialysis. Second thing is what kind of a kidney AKI it is. It is sometimes the AKI is high catabolism state. Your potassium is rising daily by 1. If you do the kidney shutdown completely, the bicarb should drop by, daily bicarb drop should be only 2 if there are no other additional factors. So in such case, high catabolic AKI, you may need to dialyze them daily. Like rhabdomyolysis AKI, initially you may have to dialyze them daily. Toxicity AKI, you may have to dialyze them daily. Then comes a second set of patients where they are multi-organ failures. Not only kidney is affected, there are multi-organ failures where there comes a CRRT. Again, there people have tried using 30 ml of per 30 ml per minute versus 40 ml per minute of fluid hemodiafiltration rate, but there are no significant advantage of going beyond certain limits. And again, in CRRT, anyway the mortality is very high. Dialysis is not the only thing which decides the mortality. And second thing I would like to add is whenever we need a space for a volume, then we can dialyze them more. And in stable AKI, if you are able to manage electrolyte and volume, and there are no drug toxicity, then there is no point of increasing dialyzing dose further.
Yeah. So I think we have good evidence that if it depends on the patient to patient and with the modality, but higher, like generally recommendation is 25 ml per kg per hour instead of 40 to 50, and there are 2 major trials which have shown that there is no difference between high intensity and low intensity therapy. I think with the time I will conclude here. So basically dialysis is very subjective thing, and we have to coordinate with the nephrologist, critical care consultant. Then we decide when to do dialysis, and according to our facilities and logistics, we should go about the modality of dialysis. Thank you.